abdominal pain. This was our ultrasound examination. We can see the uterus, and it was normal. On the right side, we can recognize a lesion and a multilocular solid tumor with anechoic cyst content. On the left side is visible another mass with the solid morphology and some irregular cystic area inside. Both masses were vascularized at color Doppler examination. Color score 3, I think. Now, what's the next? We have So, Antonia.
No, Francesca, I was just, I wanted to repeat in my mind. So transvaginally, we can already say that there are 2 malignant ovarian lesions, right?
Right, I agree.
By using pattern recognition, personally, I would exclude borderline because they are different and no papillary projection. One could have a suspicion of metastasis. Ahmad, do you
I was thinking the same. So when you said what the next step, I was thinking of see if I can do CEA and CA125. I don't know, just because I like the CEA for differentiating with GI origin. But yeah, I was thinking this could be CA153 with her history of breast cancer.
Okay.
So I don't know the tumor markers. Any tumor markers been done?
Yeah. Before that, I agree with you. But my next step was to assess the patient with the transabdominal ultrasound examination to assess the spread of disease. On the right of the screen, this is the video showing ascites in the abdomen and the tissue, the omental cake, this tissue between the bowel and the abdominal wall. Back to the transvaginal examination, we saw also tissues, some small nodules in the pouch of the Douglas, suggesting peritoneal carcinomatosis. Now, how to make the diagnosis? I agree with Antonia. First of all, pattern recognition, but we can use Adnexal model on rats.
Okay, let's move on to the 2 models before discussing the pattern recognition. Yeah.
So we can apply the Adnexal model with this lesion, the left lesion, that was the target 1.
Why to the left?
Because we have 1 multilocular solid on the right and 1 solid on the left. So the worst morphology was on the left solid, and we apply this model on the left. These are the clinical ultrasound characteristics of patients that we need to apply the Adnexal model. So age, type of center, morphology of the tumor, solid, the largest tumor diameter, 42 millimeters, and the maximal diameter of the largest solid part. No papillary projections, no shadowing, ascites present. The C125 was 423. So after plotting these variables into the model, we can calculate the risk of malignancy. That was very high. So according to the Adnexal model, the lesion is malignant, and the highest relative risk was for advanced ovarian cancer. System.
Yeah, I don't know whether we already described that, but inside it's a lexicon. So if you don't have any computer, you can't calculate Adnexal. You can scroll this piece of paper and you can look for the correct description, and we can find that the lesion is located here. Solid, irregular, any size, color score, any. So again, right, very high risk. And so, Francesca?
And so, according to the management suggested by the ORAT system, the patient should be referred to specialized care.
So, Hamad mentioned tumor markers. So, we wanted to answer to this question, looking, you can move on, Francesca, just to mention the consensus statement that you can find in several journals, because these 4 scientific societies published this consensus. So according to this consensus, we can either use Adnexal or lexicon of ORAS, and after the definition of high risk of malignancy, you can move on to the next one. Within the Gynaecological Oncology Referral Center, how do we do? It depends. For sure, we have to check for C125, which was elevated. Then we could ask for additional tumor markers, and I wanted to spend 2 words. Why don't we have a suspicion of stromal tumor, for instance, granulosa, or germ cells tumors? Because those 2 categories are almost always unilateral. That could be of some value. So it's unnecessary to check inhibin B or LDH. So this situation can be either epithelial, bilateral, high-grade serous carcinomas, or could be metastasis. Do you agree, Matt, with this interpretation? So, for sure, we assessed, as Francesca said, the extension of the disease, and by using ultrasound, and we have been working on that to look for some criteria of inoperability. But usually also perform CT scan to assess eventual distant metastasis. So after the application of this test, we can decide if it's perhaps a primary ovarian cancer or a metastasis. For metastasis, of course, we will use colonoscopy or gastroscopy. Gastroscopy, perhaps not because it doesn't look like as a Krukenberg. We will see. Let's move on, Francesca.
So
but please.
Additional diagnostic test. So I agree, CA125 and the CT scan. In this lady, the CT scan showed bilateral adnexal masses with the solid and cystic components. The peritoneal carcinomatosis and ascites were also present, whereas CEST CT scan was negative for any pathology. This is the laparoscopic view. This is the right mass. And this is the left mass. We can move on. So it was the surgery, and the residual tumor was 0. Macroscopy, right ovarian mass and left ovarian mass, solid with cyst areas. And the final histology report was positive for high-grade serous ovarian carcinoma.
So you can go on, Francesca, because we decided also to mention the next steps. So first of all, important assessment before surgery. Then to try to have the best surgical team, because the most important prognostic factor is to reach residual tumor 0. But then what happened?
The somatic testing for BRCA mutation was positive. Then the germline tumor testing was positive as well. And then, because there was also a family history of breast cancer, the patient was BRCA1 mutation positive. So we asked her sister to be tested for BRCA mutation, and the test was positive. So at the moment, a prophylactic oophorectomy was recommended. I don't know if Amanto, do you have any comment about that?
No, just my only comment is about doing the laparoscopy for the ovarian cancer. I just want to know whether this is done on the day. So do you do it on the day, or you do it and wait for histology and then you do the laparotomy later? Because we know the management normally is a laparotomy to do the macroscopic.
Exactly. I show just the laparoscopic view, but the surgery was laparotomy with the site reduction, and the visual tumor was 0.
Yeah. So the debate about this from the ESGO is, yes, we're still debating. Many of us, we still do laparoscopy on the day if the time of the theater slots allow. So we have the problem. We have an amount of time that if we use it less, it's not good. If we use it more, it's not good. So we cannot plan doing a laparoscopy plus minus big operation on the same day, and that's laparoscopy first. Then the patient later come back in 2 weeks or 3 weeks to have the surgery. There is that theoretical risk of port metastasis, and it is going about 35 from the charity data, 35%. But however, the prognosis didn't change. So although the staging went up, but when we look at the overall survival, it didn't change. So I just wanted to know that that's the debate there, that some of us still want to do a keyhole surgery first. Some of us still can go with a small cut and extend it after for that particular metastasis. And
to the next case, Francesca.
Please, Antonia, can you present our second clinical case?
So this lady was 38 with no family history, nothing relevant on past history and personal history. She underwent transvaginal scan. She was completely asymptomatic. And here, for those among you with some experience on transvaginal examination, they will recognize by using pattern recognition a specific diagnosis, because we are in front of a nuclear lesion with several papillary projections. We can see the internal surface of this lesion. Perhaps you observed a normal ovarian parenchyma, a percentage of normal ovarian parenchyma, and this was on the left side. On the contralateral side, we can detect this is the ovary. Within the ovary, again, unilocular solid lesion with one papillary projection. And pay attention at the vascularization, both in the previous one and also in this one. There is no such rich vascularization, but we can see this vessel penetrating in a perpendicular, quite regular manners. This is the summary of ovarian tumor. But if we are not so experienced and we wanted to use IOTA models, Francesca, we can try to use. So we have to collect the most important parameters. We need age, center, the type of tumor, largest tumor, larger diameter, more than 3 papillary projections, no shadow, no ascites, and CA125 is negative. That's not a surprising finding because in almost in so many borderline ovarian tumors, CA125 is negative. After plotting the variables, we can calculate by using Adnexal. The result is much higher than 10%. So Adnexal is telling us it's malignant, but the highest relative risk corresponds to borderline. So do we need additional tests? Oh, sorry, I already answered.
Was answered, but
I influenced your opinion, but we put this question just to try to understand what of these lesions. Could it be a cystadenophylloma? Not really, because cystadenophylloma usually is characterized by 1-2 papillary ejection, hypoechoical with shadow. Could it be a granulosa cell tumor? No, granulosa usually solid with the regular cystic areas, monolateral. Clear cell carcinoma usually solid, irregular. So it's so clear that it's a borderline, perhaps a borderline. So tumor markers, negative. CT scan showed even here it's not a surprise that CT scan only recognize the right unilateral solid disease. Just to repeat that it's very useful to look for lymph nodes for distant metastasis, but not for the characterization of ovarian tumor. So she underwent laparoscopy. And there is a question from the audience, was laparoscopy, why laparoscopy? So for these situations, possible surgery by using laparoscopy. Do you agree, Ahmad?
100%.
Okay, so here we can see the left lesion with normal ovarian foramen. And so this patient underwent a right salpingo-oophorectomy and left cystectomy. In other words, a fertility-sparing surgery. After, let's look at the final histology so we can compare the image, the 3D, and the real aspect of the internal surgery. Bilateral serous borderline ovarian tumor. So please, if you want to remember the fact that within the borderline there are atypiae, there is no stromal infiltration, and there is a sort of how do you say in English, Ahmad? Hierarchy. I don't remember. I can't Hierarchy, exactly. So an organization, that's why if we check correctly the vascularization, we can see vessels penetrating perpendicularly because it's not so bizarre like high-grade serous carcinoma. So after that, after histology, the patient can conceive, can try to become pregnant, but we have to follow up these patients using what? Which kind of a diagnostic tool? We usually perform routinely ultrasound examination. We usually also test CA125, but it's not so useful. So, and we do that keeping in mind that an eventual detection of recurrence is possible, is clear, easy to detect by using ultrasound. We can detect very lesion. And how can we counsel our patient? Of small recurrent lesion within the remaining ovary. We can do nothing. Nothing. We can simply follow these patients. Why don't we perform immediately surgery? For two main reasons. Because if the lesion is within the ovary, When we perform laparoscopy, we are not able to find it. We should open in several parts the ovary to find it. And for a second reason, because if we perform immediately surgery in 2, 3 months, 4 months, in addition, a further recurrent lesion could be visible. So it's better to wait to let eventual small areas of recurrent lesions to become visible. In front of you, just an example of a lesion detected at the size of 10 millimeters, and Dorella Franchi could be able to scan the lesion until the size of 3 centimeters, when the patient could undergo another fertility sparing surgery. So this is important, and the growth rate is 1-2 millimeters per month. It happened to us, this case, with 3 borderline tumors. So monolateral oophorectomy, you can play it, Francesca. Monolateral oophorectomy and contralateral cystectomy. A recurrent lesion of 10 millimeters, something like that, was detected. During laparoscopy, it was almost impossible to understand exactly what it was. So in this case, we can guide the surgeon to find the recurrent lesion by using ultrasound. And we can do that both transvaginally or, in this case, laparoscopically, because we had this laparoscopic probe, and here the probe is located there, and we could detect the normal ovarian parenchyma and the lesion. So we could provide, again, a fertility sparing surgery. So, Hamad, I don't know if you want to add, we included this case because diagnosis is so typical. We can perform laparoscopy, histology, and follow-up.
Yeah, I think that's amazing. I would love to have the laparoscopy probe, because for me to do it when I have gas in the abdomen is a bit difficult. I have to fill the abdomen with some water and leave the ovary floating, so I can have an acoustic window to do a transrectal or transvaginal ultrasound scan, and there will be 2 operators, and normally I do it from down below, and then I mark it from the top with a diathermy. So, but with an abdominal or laparoscopy probe, this is much easier. So that is, congratulations, that's really good facility, and it works really well.
But again, talking, we know that our listeners are from so many countries and they do not have a laparoscopic probe. Is it really useful? As Hamad has just said, it's not so useful always. You can guide in several occasions. It's sufficient to have a transvaginal scan by the surgeon to find a recurrent.
Absolutely. You just need to leave so either deflate the gas completely, some water in the middle to try CO2 in, you will not be able to see.
Exactly. Now, Francesca, next case.
So, 69-year-old patient with no family history of cancer. She had a previous gastric cancer. She was asymptomatic, but there was a diagnosis of pelvic mass at CT scan during follow-up. This was our ultrasound examination. We can see a solid right solid mass of 45 by 28 by 54 millimeters, and this was the vascularization. This is the contralateral ovarian mass, solid morphology, and it was 60 by 28 by 56 millimeters, and the vascularization was rich. So bilateral solid tumors with rich vascularization. So we can apply the Adnexal model to make the diagnosis. 68-year-old patient with solid tumor. The largest tumor diameter was 60 millimeters and the large solid component as well. No projection, no shadowing, no ascites. We don't need the color score to apply Adnexal model, and the C125 was negative. This is the lesion, and these are the clinical ultrasound characteristics. So we can apply the Adnexal model. We calculate the risk of a malignancy that was more than 10%. That is the cutoff that we usually use to calculate the risk of malignancy with Adnexal. And the highest relative risk was this one for metastatic tumor. She underwent surgery and she had an hysterectomy, bilateral salpingophorectomy, and this was the macroscopy, bilateral solid masses, and it was the histology. Krukenberg tumor.
Okay, thank you. I think that there are no additional comments. We can move on, perhaps, because we have only 4 minutes left. I would like to share with you these 2 cases because put together 2 ladies, similar age, 48 and 47. So let's look at the examination of this lady. Incidental finding of a multilocular. So very innocent lesion, actually. So score. We were at the beginning of IOTA 5 protocol, so we offered the patient to be included in the study. Similarly, 47 years old, asymptomatic, a diagnosis again of the variant 5 centimeters, known for the first diagnosis was 12 months before. She was also included in IOTA 5. And we can see here the variables, 1 locule, 7 centimeters, ground glass appearance. So the hypothesis was endometrioma. The 2 of them were cancelled, and today we can cancel our patients with some data. In particular, we can move on quickly. We can tell them that there is a very low risk of torsion, very low risk of rupture, and the cumulative incidence to become invasive or borderline is very, very low. So let's look at the natural history of this lady. According to the protocol, she was examined again after 3 months, and it was completely unchanged. After 6 months, 3 locules, and the appearance of a ground glass in 1 locule. So instead of 12 months, she came back after 6 months, 4 locules, stable. So next scan was planned after 12 months. Because of an increase in number of locules, the patient decided to undergo surgery, and the final was a mucinous cystadenoma. But what about the other one? So remember, unilocular, 7 centimeters, after 3 months, completely unchanged. So after 6 months, next step, unchanged. After 12 months, according to the protocol, 7 centimeters, ground glass, endometrioma, but then after 12 months, the content changed a little bit, and there were some papillary irregularities, I would say. So she was invited to come back after. You can continue with the click after 6 months, and the appearance was completely different. So 4 papillary projections and 12 centimeters in size. The final histology of this patient was clear cell carcinoma. So we can conclude in 20 seconds that longitudinal assessment is possible. The risk of torsion, the risk of rupture is very low. Malignant transformation is rare, but can happen. So we have to consider the whole clinical situation of our patients to be able to counsel our patients appropriately. Thank you.
Thank you.
Well, thank you, both of you. If you could stop sharing, that'd be fab. Great session, everybody. Can I just follow up on the endometrioma story there? I don't know what, Ahmed, I don't know what your views are, but in a situation, I know, masses that look like an endometrium in postmenopausal women, you do have to be particularly cautious about, I think is fair to say. But what's the position now, Ahmed, on having let's say I have an endometrioma and someone who's 45? Are we worried about that and just say, well, we can manage that and follow it, or do you have to, or do you take them out on because you are concerned that there may be malignant transformation in endometriomas now?
Thank you. I mean, I have to say, as a cancer surgeon, I'm biased because
I know you are.
Very much biased. You're very much biased.
I can't believe you haven't got like a scalpel in both hands. Speaking to us.
Absolutely. The reason why is I see all these clear cell cancers and endometrioid adenocarcinoma, which they come with a background with a history of endometriosis. But I know well, when I was a junior trainee, I did a systematic review on all endometriosis, all the studies, and the risk or the relative risk we found in this places to be 1.2 relative risk for endometriosis to turn into cancer, which is not clinically significant. So when you talk to an endometriosis patient, you tell her, look, you do have endometriosis, one of the questions will be, will I have cancer? So that would change the whole thing, because if I say yes, that means do we have to take endometriosis regarding symptoms to prevent from ovarian cancer, which the answer to this now is not. We have to. But there are these particular cancers, clear cell carcinoma or endometrioid adenocarcinoma, they do come with a background of endometriosis. So that was a very interesting story. Professor Testa, gave us about the natural history of clear cell carcinoma. So that is really good. And I'm sure you published this one or somewhere, because that's really, really worth publication, because it shows in the time how endometriosis can change into cancer. But we don't have to take endometriosis out for 45 just because to prevent from cancer. That's the answer.
Yes, I think it's important that you brought up the IOTA-5 study, because I think that's good. I think it's great to have that evidence. Particularly, I think a lot of people would be surprised by the the relatively low risk of torsion as well as cyst accidents. And indeed, I think you've probably looked at the paper more recently, but if you look at the size of lesions, you had to get up to certainly over 7 or 8 centimeters before the risk of any kind of cyst accident became significant. So this whole thing about 5 centimeters being a magic cutoff really didn't hold in the data. Okay, I think we've got to finish now because the people behind the scenes, I don't know what the audience, I can tell you they're terrifying and they're very nasty to us if we run over time. So I just want to thank the three of you and first of all, thank Thierry, fantastic, thank you very much, and the three of you for sharing some fantastic cases. I know, Francesca, your cases are so beautifully presented and illustrated, and I can imagine that must take a long time, a lot of work to make those presentations look as good as they do. I appreciate that, and I'm sure everyone else appreciates it too. And the same theory, you are also the master of the entertaining slide and illustration and illustrating things very well. So, great, when it's illustrated beautifully, I say it's appreciated. Ahmed, thank you very much. What are you going for?